Thank you for being here. This is Dr. Ruth Roa-Navarrete. She is a clinical prescribing psychologist and an Air Force psychologist with 23 years of service. Also a graduate of Alliant International University's third cohort as part of a formal Air Force postdoctoral fellowship program. Dr. Roa-Navarrete has been prescribing independently since 2010 in the context of multiple assignments in the U.S. and overseas locations and during 2 contingency deployments. Her areas of interest include women's mental health and transcultural psychopharmacology. Also an adjunct professor for Alliant since her fellowship. Welcome, welcome, welcome. Thank you for being here.
Thank you, Phil. Thank you for the kind introduction. What we're going to talk about today is military mental health, with an emphasis, of course, on psychiatric medications. I'm drawing more on my experience as a military psychologist to talk about what could potentially make a service member not worldwide qualified or not ready or fit for duties. I venture to say that every now and then, or maybe more often than every now and then, folks encounter active duty reservists and guardsmen or women potentially in their clinical practice, and that word to the wise with regards to how to prescribe to these individuals, how to treat their mental health conditions without potentially harming or impacting in a negative way their ability to serve in the military may be useful information. I do want to say that my experience has been mostly in the Air Force. I have tons of clinical experience dealing with members of the other services, and that's what I'm drawing from. But of course, my area of expertise is the Air Force. I'm speaking only from my personal experience and not in any way representing the Department of Defense or the Air Force, in as much as I share Department of Defense, Air Force, Navy, or Army policy. It is all publicly available. The other thing that I would like to share is that I don't have any conflict of interest. I do not have any financial ties to any pharmaceutical companies. So what I'd like to tell my students when I teach in the psychopharm class is I'm equally able to criticize any of the psychiatric medications that are in our pharmacopoeia. Or praise, depending on their benefits. Our agenda is to talk a little bit about definitions, what recruitment is, what retention is, pretty self-explanatory, but I'll define it in terms that are hopefully pretty familiar to you all. What it means to have a temporary duty limitation, how the services compare in terms of limitations that they place or potential impact with regards to serving when you are experiencing psychiatric illnesses or are taking psychiatric medications. Talk a little bit about medical evaluation boards, and then just give you a brief summary with some recommendations about how to practice. So with that, let's go ahead and dive in. Here's some definitions. Policy and guidance. There's multiple sources. Again, these are all publicly available, and you can look them up. You could Google them. You can read them if you have trouble sleeping. These are probably good reads, but I'm drawing from, the most important aspects of what you need to know. The main form of guidance, especially for enlistment, which is essentially the first appointment to serve in the military component, is the DoD instruction, or Department of Defense instruction 6130.03, which talks about standards for military service. There's a volume that covers appointment, enlistment, or induction, and a second volume which covers retention. And as I talk, you'll understand why there's a different standard for recruitment versus retention. In short, the reason for that is because we don't just kick people to the curb when they become psychiatrically ill. We do have high standards for enlisting only members that meet a certain threshold of psychological health. But again, we don't just kick them to the curb when they become injured. We treat them and hopefully return them to duty. So the retention standards are somewhat different than the recruitment standards. And I'll highlight the fact that for recruitment purposes, all the services use the same criteria. The Army has a specific regulation with regards to standards of medical fitness. So does the Air Force, and again, so does the Navy. I warn you that I might use abbreviations or acronyms. It's military speak. I'm used to it. When I talk about DoDs, we're talking about DoD instructions, or Department of Defense instruction, and the DAFMAN is essentially an abbreviation for Department of the Air Force Manual. As I said before, recruitment speaks to the initial appointment, enlistment, or commission into military service. And that could be for active duty, reserve, or guard components. It's a little nuanced to understand enlistment versus commission or appointment. But in short, enlisted members, as in non-commissioned officers, soldiers, airmen, sailors, enlist, and officers commission or are directly appointed to their post. That's just a difference in language. It's a difference between non-officer versus officer. I mentioned before, all the services use the DoD instruction as their minimum standard for recruitment. Retention is essentially fitness for continued military service. Is there anything medically, psychologically, or from any other perspective that renders the member unfit to serve or potentially unfit to serve? There's a few other definitions that are important when it comes to retention, and one of those is special duties. Special duties, including aviation or flying, and many others, are duties that require special skills, attention, or levels of responsibility. So those are the things that we are highly sensitive to with regards to those members being fit and or potentially having some disqualifications. And I give you some examples there on this slide. We're talking about things like, as I mentioned, flying duties, nuclear, submarine, air traffic control, arming, which does not just include arming during the deployed contingency, but also arming up as part of your daily military duties, such as military police, the Office of Special Investigations, criminal investigation duties for security forces, and so on and so forth. Duties such as recruitment, military basic or technical training instructors are also considered sensitive duties. As you may imagine, recruiters and military training instructors have a high degree of authority over very, very young and vulnerable folks. And so it is also imperative that they are screened and that they maintain a high level of psychological health, as well as SEER instructors. And here goes my first abbreviation. SEER stands for survival, evasion, rescue, and escape. So these are the folks who teach others how to survive, evade, be rescued, and escape from captivity. I already mentioned special forces or operators such as rangers, EOD or explosive ordnance disposals, snipers, and folks who have a top secret clearance. And those are just examples. There's plenty more in each of the services. I forgot to mention that the reason that we don't have standards for Marines and Space Force it is simply because the Marines use Navy standards, medical standards, since their medical needs are taken care of by Navy Medical, and the Space Force similarly is guided by Air Force standards. But there are some deviations in what may constitute a retention issue for some folks in those services. And then a couple more definitions, what it means to have an unsuiting condition versus an unfitting condition. So unsuiting simply is a condition that renders somebody incapable of service, but either preceded service, such as ADHD, as you know, it has to be diagnosed before the age of 6 to be consistent with DSM-5 criteria, or disorders that are considered the result of problematic behavior. And those include things like paraphilias, substance use disorders are good examples, impulse control disorders, and a few others. Personality disorders fall into this category as well. And these disorders in general are considered non-compensable. And, I'll explain what that means when we talk about medical boards. Unfitting refers to conditions that render an individual incapable of service, but were either incurred, meaning they happened, they first were diagnosed or first developed while the person was serving, or were exacerbated by service and are subject to medical retirement and therefore are compensable, meaning they can get VA benefits. Now, these are conditions that even if they had manifestations before the person was recruited, for example, history of depression or anxiety in adolescence that later manifest when the person is serving, was either sufficiently in remission or manageable at enlistment so that the service basically is owning any responsibility for exacerbations during services. And these are the majority of prefix diagnoses, not all, depression, anxiety were mentioned, things like PTSD or trauma-related disorders, and quite a few other psychiatric conditions are considered unfitting. So in terms of recruitment standards, there's one primary set of recruitment standards, as I mentioned before, that are followed by the military entrance processing stations, or MEPS. If you have any experience with military members, you may have heard of MEPS. MEPS is the medical station where every person who is joining the service is screened for medical and psychiatric conditions. And these are mostly run or primarily run by the U.S. Army, following the DoD instruction that I mentioned before, and that's why there's only one set of recruitment standards. If you look at the MEP standards, there are a significant list of what they call disqualifying psychiatric conditions, and you might be surprised to see some of the conditions that are listed there. But I do want you to keep in mind that the majority of these conditions are waiverable. Not all, but the majority of these are waiverable, meaning that if the person does have a history, it's documented with the help of the recruiter, they can submit a waiver showing a pattern of stability that would allow them to enter the service. I've highlighted some things that are of specific importance when it comes to psychiatric conditions that are treated with medications. Chronic insomnia, as defined by DSM, or the use of medications or other substances to promote sleep 15 or more times over the past 12 months. 15 or more times over the past 12 months is not a lot. That basically, is the equivalent of 2 weeks using sleep aids. That includes over the counter, by the way, not just prescribed sedatives, for at least 2 weeks in the previous 12 months. So just kind of bear that in mind. And then sleep-related breathing disorders, a history of narcolepsy, circadian rhythm disorders requiring treatment. Once again, this might be an area where we could see potentially psychotropic medication use that precedes service, including some of the wake agents. Most of you are probably familiar with the, medications that people use to maintain wakefulness.
You mentioned ADHD. Is there a possibility of enlistment if ADHD was diagnosed after 6 years of age? What about the medication used for ADHD, since some are amphetamine?
We'll get to that. Great question. Very timely. Here's learning, psychiatric, and behavioral disorders. Perfect segue. The question was ADHD. What if it was diagnosed after the age of 6 or even before the age of 6? It doesn't really matter. The disqualifying part of ADHD may be if they have been prescribed medications in the previous 24 months, or they have documentation of adverse academic, occupational, or work performance. The history of comorbid mental disorders is not necessarily disqualifying. Likewise, number one, a recommended IEP or individualized education plan is not necessarily disqualifying. The first two things are easily waiverable, but the last two things are probably less so. One thing that we typically see is that folks tend to taper off their medications in preparation for enlistment. And if they have a sustained period of time in which those medications haven't been needed in order to maintain, maybe not optimal, but good enough, for lack of a better way of saying it, good enough performance, then that is sufficient. And hope that answers the question. The history of learning disorders also may be disqualifying. Again, you could see if the person had an IEP, comorbid mental disorders, or adverse academic or occupational work performance, that might be an issue. And again, just bear in mind that some of these things are waiverable. A question that often comes up is, what about autism spectrum disorder? Again, it depends on the severity. Treatment records are key to the waiver process. Level of impairment, level of occupational and academic functioning are gonna be assessed. History of disorders with psychotic features, history of bipolar and related disorders are unlikely to be waivered. So those are the absolute disqualifying conditions, and there's a couple of others that I'll briefly mention. It doesn't matter whether the person is on or off medications. For depression, though, symptoms or treatment within the previous 36 months, you could see that this is a bigger time period. So that's going to be more difficult for folks to pass that threshold. But again, these conditions are waiverable, and depending on the services and their need, times of work, difficulty, just what we have now, meeting recruitment targets, all these things, may definitely have a bearing on whether or not a waiver will be approved. Any required inpatient hospitalization is unlikely to be waived. It doesn't matter what the condition is for. I wouldn't say any suicidality, suicidal thoughts, potentially even with mild intent may be waiverable, but anybody with a history of a suicide attempt is unlikely to be waived. Here's a few more. History of a single adjustment disorder. Now, that may sound pretty harsh, but again, just keep in mind the qualifier there. If treated or symptomatic within the previous 6 months, or any history of chronic lasting longer than 6 months or recurrent episodes of adjustment disorders. Now, keep in mind that this guidance or this DOD was written several years back. We no longer have a diagnosis of chronic adjustment disorder, but they provide a definition there. Any adjustment disorder lasting longer than 6 months or someone who's had recurrent episodes. History of an eating disorder may be problematic, but again, it depends on the service. It also depends on the career field and the level of symptomatology, whether this can be waived. Communication disorders can be waived. I've seen things such as a stutter or even mild Tourette's. I know Tourette's is not clearly a communication disorder, but I've seen those waived, if they are sufficiently managed or functionality is not seriously impacted. I mentioned, history of suicidality or self-harm can be problematic. History of trauma is waiverable, and I will tell you now, in general, the military attracts a lot of people who came from pretty terrible backgrounds, including, abusive homes, history of domestic violence, childhood abuse, foster care, et cetera, et cetera. So if that was a disqualifier, we would probably not be able to meet our recruitment targets. So those are definitely waiverable. But again, treatment matters. So if they've had symptoms, likewise for anxiety disorder symptoms or treatment, and treatment is defined as either therapy or medication. So just keep that in mind. As I said, this is just a minimum threshold for recruitment. Now let's talk about retention. So retention standards are definitely service specific, and they are typically also job specific. So for all the services, there are different special classes, as I mentioned, related to special duties, such as flying, nuclear, medical, etc., that require an additional, more stringent level of fitness per se. Keep in mind that a diagnosis of most of the conditions that I mentioned as disqualified on previous slides for recruitment is not automatically unfitting for retention. As I said, we don't just throw people to the curb or, not allow them to continue to serve if they have a psychological condition. The severity, the course of illness, the duration of symptoms, and whether or not they experience symptomatic relief with treatment, including with medications, are taken into account as to whether the condition renders them unfit eventually or not. There are some automatically unfitting conditions, and those include schizophrenia or psychotic spectrum disorder, bipolar and related disorders, and mental disorders that require the use of lithium, anticonvulsants, or antipsychotics beyond 6 months. And that beyond 6 months is really important because you will see in clinical practice, either in individual outpatient treatment, intensive outpatient, or even an inpatient hospitalization that folks are given or prescribed these medications either as adjunctive therapy for the treatment of depression, trauma, anxiety, etc. But if they require maintenance on these medications beyond 6 months, then they will be disqualified. So when we get them back, we typically try to, on an outpatient basis, we taper them off the medication after a sufficient period of stability, which is typically 3 months. If they cause or are expected to cause duty or mobility restrictions for more than 12 months, if they result in more than one psychiatric hospitalization, they require specialty care, and this is a very important distinction. That means care by a psychiatrist or a prescribing psychologist or a psychiatric nurse practitioner or psychologist for more than 12 months. If they can be managed by their PCM, and we all know that PCPs, PCMs have a threshold for the mental health conditions that they will manage, more than likely they would not be considered unfit. Potentially a suicide attempt may cause some issues with regards to retention. The important thing to consider is that the condition alone does not necessarily mean the person would be disqualified. They have to cause functional impairment. So the condition has to demonstrate functional impairment in order for it to be considered unfitting. So if somebody is I hate to use those words, but closeted depression or a functionally depressed individual, and they are functioning just fine, maybe not great, but just fine in their job, they are very unlikely to be submitted for a medical board. Temporary duty limitations are how we describe the restrictions that we place on a service member when they're either diagnosed initially with a mental health condition, when they're initially placed on a course of medications or treatment, or when they have been diagnosed for some time and they are consistently demonstrating duty impact or lack of ability to perform their jobs. And duty limitations are required in certain cases, but they could also be waiverable in certain circumstances. So, for example, concurrent use of 3 or more psychiatric medications, that would be a limitation that would preclude somebody from deployment to a contingency operation, such as the Middle East or, sea duties, that sort of things. Conditions that do not require temporary duty limitations are a condition that is in remission for at least 3 months, even with treatment. So if they are asymptomatic or the symptoms have been mild or non-clinical or not meet the clinical threshold for at least 3 months, they do not require what in the Army and Air Force is called a profile or a temporary duty limitation, and in the Navy would be called a LIMDU. A condition in remission without treatment also does not require limitation, or criteria, or any condition that has a Z or a T prefix does not require a temporary duty limitation. So this is meant to really highlight that problems of life, what we used to call the V codes, now called the Z codes, face of life, hurdle issues, things of that nature. Service members are encouraged to seek help, and they will very unlikely have any duty impact associated with that. I know this is your bread and butter. You guys do this every day in terms of diagnosing and treating mental health conditions. But for us, folks who are involved with service members, it is really important to key in on the fact that psychiatric disorders are different from any other type of medical diagnosis. As you know, psychiatric disorders are a collection of symptoms combined with a determination about the social and occupational impairment associated with those symptoms. That is very different from a medical diagnosis. A medical diagnosis follows a diagnostic criteria in which symptoms or lab exams, radiological findings are conclusive to the diagnosis, whether or not the symptoms cause any functional impairment. So given that we have a requirement of meeting social and occupational dysfunction to make a diagnosis, it is really important when you're dealing with service member to assess the level of impairment or performance directly and, if possible, via collateral information. So not just assess their symptoms, but assess how the symptoms impact their daily lives. Along those lines, it's also important that we consider that because of the duty implications for all the services, the F preface diagnoses are the only ones that are considered quote unquote disorders. And as such, they impact readiness, they impact retention, and they potentially impact deployments. A good example there, an adjustment disorder is an F preface diagnosis that supports that the idea that the person's reaction to the stressor is out of proportion to what is expected. A person who is experiencing a quote unquote normal or within the normal range is in proportion reaction to a stressor is probably better suited to be diagnosed with a Z code versus an F code. And that's kind of our guide for how to think about this. And just keep in mind that, I know you have to meet insurance requirements. In some cases, TRICARE doesn't always require an F preface diagnosis in order to reimburse for treatment. So make sure you check your insurance requirements, especially if service members are worried about potential impact. Okay, so I talked about recruitment, talked about retention. Now I'm going to talk about service comparison, and specifically as it relates to how we handle these conditions after they've met a certain threshold. The Army has guidance for when to refer to what we call a medical board. A medical board is essentially a review by a panel of experts, review of the record, and also review of a narrative summary written by the treating provider. of whether or not the person's condition and their documented functional impact renders the person unfit for continued service, or whether they can continue to serve with some restrictions. There's guidance with regards to what needs to be referred. So I mentioned disorders with psychotic features and bipolar disorders. If they develop after enlistment or commission, they would be automatically referred. Every other condition requires that there is persistence of symptoms sufficient to warrant hospitalization and/or persistence that interferes with duty performance. And keep in mind things like anxiety disorders, some of the neurocognitive disorders, chronic adjustment disorders may not necessarily render somebody unfit, but a review by this board may return the person to duty with some restrictions. That's true of some of the sleep disorders, including obstructive sleep apnea, that creates some duty limitations, as in, the person not being able to deploy to an austere environment where there would not be electricity and the ability to wear a CPAP. For the Navy, there are conditions that may pose duty limitations. With the Navy, I address specifically aviation. Just to give you an example, again, some of the other ones are pretty similar for continued service, but when we talk about special duties and sensitive duties such as aviation, they are much more stringent. Like the current use of a stimulant or non-stimulant medication is incompatible with aviation duty. So keep in mind, in this case, it's not the diagnosis of ADHD, but the use of a stimulant or non-stimulant that would be incompatible specifically with aviation. Obviously, schizophrenia or psychotic disorders are incompatible. Depressive disorders are eligible for waiver after completion of treatment, and they can be waivered so people can go back to flying status. It is also true in the Air Force and the Space Force. They are eligible to go back to flying status even if they're on maintenance pharmacotherapy, as long as there haven't been any treatment changes or dosage changes for a certain period of time. For anxiety disorders, likewise, members could be eligible for a waiver while on maintenance pharmacotherapy, but some medications, namely benzodiazepines, also true in the Army, also true in the Air Force, are incompatible with flying. Benzodiazepines in general are discouraged from use in the active duty component, and we recommend the same for reserve and guard members, that they are used very sporadically, because any use more than 30 days would create a limitation in terms of deployability and war-wide duties. Some other limitations associated with the Navy with regards to trauma-related disorders, again, the person can be considered for a waiver even if they're on maintenance medications. Feeding and eating disorders, it really depends on whether the person is off medication, asymptomatic, and out of active treatment for a minimum of a year. These are very difficult cases to obtain a waiver for due to the severity and the potential complications of issues associated with feeding and eating. Last one, for the Navy, psychotropic medications used within intermittent explosive disorders are incompatible with aviation duty. So once again, they don't clearly say intermittent explosive disorder is incompatible, but the medications that are used for this condition would be. Okay, for the Department of the Air Force, which includes the Air Force component and Space Force, these are the conditions that would pose duty restrictions and/or eventual referral to the medical board. Any condition that lasts longer than 12 months, that results in more than one psychiatric hospitalization, that requires a specialty mental health care at least every 3 months for a period of more than a year, suicide attempts, psychiatric hospitalizations would at least be reviewed, concurrent use of 3 or more psychiatric medications, and in the case of aviation duties or flying duties, use of more than one approved antidepressant, and not all antidepressants are approved for flying duties. So if you run into, a reserve member who is on flying status, they really need to communicate with their flight surgeon to be able to obtain a list of approved medications or any unapproved medication for mental health symptoms. And we're not talking about FDA approval. We're talking about service-specific approval. I talked about medical evaluation boards. As I mentioned before, it's a board comprised of medical professionals that evaluates the degree of duty impairment stemming from a medical condition, including psychiatric psychiatric and determines their suitability for continued service. It can be automatically started, as I've mentioned before, or after certain diagnoses. A couple of medical conditions that would prompt an automatic board would be AIDS, not HIV, but AIDS, cancer, diagnosis of cancer. It doesn't necessarily mean the person is going to be discharged, but they would be evaluated. They may result after prolonged and perhaps unsuccessful, unremitting mental health treatment to include pharmacotherapy. They typically result in medical separation or retirement, but not always. And if the person is retired, they are awarded benefits by the VA depending on the level of impairment or disability. And in this case, they assess the level of impairment, not just in their military duty performance, but social, occupational, academic impairment and future employability. Keep in mind that it may or may not be perceived by the member to be in their best interest. So, once again, if you encounter this members and you're heading into long-term treatment, it's really important to have a conversation about what it might mean and how it might play a part in what their future plans are. I could talk about this for hours. I could talk about each one of the services for hours, but it's probably more than you need or want to know. So here's some recommendations in summary and conclusion. Again, use the policy and guidance when in doubt or consult with colleagues. If your job is near a military treatment facility or a military base or post, you could always reach out to the base with questions. Most of us are pretty happy to entertain those questions and help you out. Also, it's important to discuss with your client, the service member, their desire or interest in continuing to serve. A lot of folks approach their mental health treatment as, I don't really care what happens to my job. I just want to get this over with, or I just want to be treated. Others are very cautious and leery, and they avoid mental health treatment because they want to protect their career at all costs. So you want to be very open with your patient about having those conversations. As I mentioned, remember the nuances of diagnosis. TRICARE does not always require an F prefix in order to reimburse a treatment, but some insurance companies do. Keep in mind the functional impairment piece of diagnosing. Also, remember the ability to prescribe also gives you the ability to unprescribe. So if you see somebody who's on 3 or 4 different medications, and believe me, I have seen them, I have taken them back from civilian care with, 3, 4, 5, 6 different psychotropic diagnoses, you can clean that up, or you could at least try to clean that up, or have a conversation with the member about whether it's in their best interest to continue to maintain that regimen instead of simplifying. Sometimes you need all of that, but not always. Again, just be cautious about antipsychotics and anticonvulsants. I know it's fashionable, or it was fashionable for a while, to augment psycho or treatment of depression with, things like Abilify and Latuda and things of those lines. And, if you don't really need it, we don't need to go there. Again, be transparent and have open conversations with your patients. The other thing that I would highlight is that in general, we work under the presumption of health, meaning we put our members through the test. Military members are resilient, capable, and resourceful. I mentioned the fact that they come from difficult backgrounds, but they also are trained and battle tested to withstand stress. And so our job, our goal is always to treat as little as possible, not necessarily undertreat, but what I mean is as little as possible in terms of polypharmacy to be able to restore the person to 85% of functioning. And not necessarily to cure or resolve. Also, remember that they have supports beyond their family or their immediate circle. And so sometimes if anything more is needed, it may not be resolved by an additional medication, potentially by encouraging the person to open up to their friends in the unit, to their leaders, organizations on base that may help them to restore some of their resilience.
If a member could benefit from psychotropic medication like Zoloft, but they are afraid to start because they worry it will take away security clearance or similar job status, what would you say to them?
I'd say not to worry. I have seen people obtain a top secret clearance and move up from secret to top secret after being placed on a psychiatric medication. There have been repeated studies about this, even studies that compare impact on security clearance from medical conditions as opposed to, compared to psychiatric conditions. I believe the numbers are somewhere like 99.7% of members did not experience any impact specifically on security security clearance. If they experience any impact on security clearance, it's typically the result of their behavior, because security clearances measure your judgment and reliability, and behavior is a good demonstrator of your judgment and reliability. So failure to treat a condition that could potentially impact your behavior in a negative way could have worse repercussions. I would say with something like sertraline, for sure, not to worry. What I've seen, at least, is that people worry more about, quote unquote, a label. It is important for folks to understand that the functional impairment associated with the diagnosis is much more relevant to potential duty implications. And as such, an untreated label, an untreated diagnosis may be more problematic. To kind of piggyback on my comments about security clearance, every now and then we have to make a review of a medical record in order to render advice or an opinion as to whether or not somebody should have their clearance renewed or elevated. It is more likely that I will raise questions, and most of my colleagues will raise questions if there's a loose end, if there was a recognition that a condition was present, but the person never sought care or never completed treatment or seemed to start and then drop off, because then we don't know what the current level of impairment is for that person. If it's pretty clear in the record that they started treatment, benefited from treatment, and then they terminated at an appropriate time, and when their condition was, either significantly improved or resolved, then it's a clear yes.
Do service members prefer working with independent psychologists when on active duty, so their diagnoses are not shared with the military? Is it helpful for them to see an independent provider for that reason?
Some do and some don't. It depends on their current situation. And I'll give you a couple of examples. I would say that service members who are part of, this newest generation, the Z Geners, are very open to working with anybody, anytime, and disclosing their mental health condition, no matter what. And they don't really have a lot of qualm about potential duty implications. They just expect folks to receive treatment and get better, and then use it as often as necessary. But every now and then we do find somebody who has a preference for working with a civilian provider versus somebody who's affiliated with the military. Folks who are older, folks who have been in the service longer, and who are more established and usually higher ranking, it depends on where they are in their career. Oftentimes, at the end of someone's career, it becomes imperative to document and have a service-connected claim, or to be able to verify service-connected claim with the VA. And so that's when folks start really making sure that their records, their military health records, indicate that they have a diagnosis or a condition, even if they have avoided military mental health throughout their careers. Even though they may have worked with somebody independent before, it becomes more important to have those service-connected conditions documented in their military records later on. Anybody who's getting, especially if they're using TRICARE versus private pay, those records are going to be available to us through MHS Genesis. The one caveat is that Guards members and reservists, because they're only on active duty orders, therefore only on TRICARE benefits during during drill time, they may not use TRICARE. They may use their private insurance, or they may use self-pay. And so we may not see those records. Every member of the reserve components is responsible, though, for notifying their medical unit if they receive care.
Thank you for being part of such a wonderful program. I truly believe that this program saves lives by giving better access to trained people to be able to offer pharmacology to folks. So this program, I think, is very important. Thank you both for this and for what you've done over the years for the program.
Excellent. Thank you, Phil. Thank you, everybody. It's been a pleasure.